Hello, is my voice audible now? I am good, Nani. Good evening, Ramesh. Please confirm if my voice is audible now. I hope I should be audible now. Yes, good. Thank you, Revati, Hemant, Rashmi, Guevara. Okay, right. So we are good to go. So we welcome you again to the second part of the pediatrics revision. So just like yesterday, we will be revising some very important must know topics from pediatrics. So yesterday we dealt with the general pediatrics topics, and today we'll be moving on to cover some topics from neonatology and from systemic pediatrics. Okay. So again, I want it to be an interactive session. Okay. So I'll be waiting for your answers and do try to imbibe as much as possible. So it is a revision. I'm sure you guys know all of this, but it is very, very important in the last few days, to revise and to consolidate things together, right? Okay. So starting with some topics in neonatology, first and foremost, the very important neonatal resuscitation guidelines. We all know the neonatal resuscitation guidelines now begin from the antenatal period, right? So they start with antenatal counseling, team briefing, and equipment check. So once you do that, the baby is born, and then we ask three questions. What are the three questions? Very important. Whether it is term gestation or not, good muscle tone or not, breathing or crying or not. If everything is fine, then the baby stays with the mother and gets routine care. What do you mean by routine care? Keep the baby warm, maintain the temperature of the baby, okay, maintain the airway of the baby, clear the secretions if required. You don't suction the airway of all the babies, okay? You only suction if required, right? And ongoing evaluation. Now, if the answer to any of these three questions is no, then what do? You will do same things as you did in routine care, plus you stimulate the baby. You do some physical stimulation by rubbing the back of the baby or flicking the soles of the baby, right? And then you assess and see very important things. What are they? Whether the baby is having apnea or gasping, or if the heart rate is below 100 per minute. If any of these is there, then what do? You have to start positive pressure ventilation. And this positive pressure ventilation we do using bag and mask, right? And you use a SpO2 monitor, consider using a ECG monitor. If there is labored breathing or persistent cyanosis, then we use CPAP. What is CPAP? Continuous positive airway pressure. Very important. Continuous positive airway pressure. And we monitor the saturation and we clear the airway, gives oxygen if required. Finally, when the resuscitation is done, you do post-resuscitation care and team debriefing. Okay. Now, if the heart rate was less than 100 per minute, what do? So remember, we've already started positive pressure ventilation. Still, the heart rate is less than 100 per minute. What do? You check whether the positive pressure ventilation that you're doing, chest rise, is happening or not. Whether the positive pressure ventilation is happening properly or not. And take ventilation corrective steps if required. Right? And you can do endotracheal intubation at this time. Now again, you reassess if the heart rate is less than 60 per minute or not. If it is less than 60 per minute, start chest compressions. And what is the ratio of chest compression is to positive pressure ventilation that is recommended in neonatal resuscitation? A very important must know topic asked multiple times in the MCQs. Yes, tell me. What is the ratio of chest compressions is to positive pressure ventilation that is recommended in neonatal resuscitation? Very good. Mukesh, Rashmi, Amritansh, Kapil Dev, Niyati, Sneh, Siva, Divya, Ankur, Teja, Guevara. Very good. So it is 3:1. So you give, for every 3 chest compressions, you give 1 positive pressure ventilation. So 1, 2, 3, squeeze. 1, 2, 3, squeeze, like that. So chest compressions and positive pressure ventilation, the ratio 3:1. And the best indicator of adequate ventilation is improvement in heart rate. And when you check the saturation of the baby, you have some target saturations. At 1 minute, it is okay if the saturation is between 60 to 65%. And then with every passing minute, go on increasing by 5%. So 2 minutes 65 to 70, 3 minutes 70 to 75, and so on. And by 10 minutes, the expected saturation is 85 to 95%. So you can see never we are targeting a saturation of 100%. At 10 minutes also 85 to 95% is good enough. Now, despite your chest compressions, if the saturation is not improving and the heart rate is not improving, then you use injection adrenaline or epinephrine. And despite that, if it is not improving, you have to consider alternate causes like hypovolemia or pneumothorax and manage accordingly. So that is the neonatal resuscitation, right? Okay. So what is this, guys? What do you think is this? So this can come as an image-based question for you. So what is this device which is used in neonatal resuscitation? So this is a Yes, waiting for your reply. So, okay, this is called a ambu, and this is actually basically a self-inflating bag. Why self-inflating? That means you squeeze it and you release it, it gets inflated on its own, irrespective of whether you have connected any oxygen or any gas supply or not. So, it is a self-inflating bag and a mask. So, this is the mask, and with this is a reservoir. This, this you can see a bag like thing which is there. This is a reservoir that helps in the increasing the FiO2 delivered to the baby. Okay, so it increases the oxygen concentration delivered to the baby, right? And this is the oxygen tubing. So this is a self-inflating bag and a mask with reservoir and with oxygen tubing we used in neonatal resuscitation, right? It is used for delivering positive pressure ventilation. So we know one very important contraindication of positive pressure ventilation, the condition in which you will not do bag and mask ventilation. So contraindication to bag and mask ventilation. Very, very important question. Who is going to answer? Let us see. So must know question asked again n number of times in your various MCQs. Very good. So Teja, Nani, Rain, Sneha, Mukesh, High Tracker, Pushpendra, Sujit, Dhwanveel, Sarika. Very, very good. Dopamine. Nice name. So it is congenital diaphragmatic hernia. So if the baby has, suspected or diagnosed congenital diaphragmatic hernia, you do not do bag and mask ventilation, because instead of improving, the condition of the baby is going to worsen with it, right? So moving ahead to some questions. A baby was born limp and was having apnea. Okay, what will you do next? So remember, in your neonatal resuscitation guidelines, what did we see? If the baby is having apnea, what do we do? Give chest compressions, give oxygen, umbilical vein catheterization, or bag and mask ventilation? What do you do? So Dr. Rain, Dopamine, Akash, Mukesh, Chanchal, Hazala, Amritansh. Yes, you're right. So you do bag and mask ventilation. So going back to the guidelines, you can see. So whether if there is apnea, you can see here there is apnea. So if there is apnea, you do positive pressure ventilation using a bag and mask, right? So the best answer to this question is bag and mask ventilation, right? And if the heart rate goes less than 60 per minute, then you do chest compressions along with bag and mask ventilation, right? Okay. What do you mean by essential newborn care? So recently in the Fmge exam, you were asked about all of the following are the components of essential newborn care except. So we need to know essential newborn care includes immediate care at birth, that means receiving the baby, drying up the baby, providing warmth, that is thermal care, clearing the airway if required, okay, doing suction if required, and ongoing evaluation, resuscitation when needed, support for breast milk feeding. So breastfeeding, early initiation of breastfeeding is a very important part of essential newborn care, nurturing care, infection prevention, taking strict aseptic precautions, washing your hands, okay, and using a clean cord tie, clean blade to cut the cord, and so on. Assessment of health problems, that means ongoing evaluation, recognition and response to danger signs, and timely and safe referral when needed. So all these are components of essential newborn care, you can see, right? So moving on to our next question, which of the following is not included in essential newborn care? ENBC is essential newborn care. Dry the baby, breastfeeding, ear care, temperature maintenance. Yes, waiting for your answers. So which of the following is not included in essential newborn care? Whether it is dry the baby, breastfeeding, ear care, temperature maintenance. Yes. So Priyanka, Amritansh, Guevara, Anna, Dr. Mesh, MS, Mukesh, Flamingo, all of you are right. Very rightly said. So ear care is not a part of the essential newborn care, but drying the baby, breastfeeding, temperature maintenance, all this we saw are components of essential newborn care. Moving ahead to another very, very basic but very important thing that has been often asked in MCQs. So what is kangaroo mother care? So you must have seen a kangaroo. Kangaroo keeps the baby in its pocket in contact with its own skin. So kangaroo mother care basically refers to skin contact between the baby and the mother. It is usually given by the mother, but it can be given by father or any other caregiver also. So skin to skin contact. So baby is kept in skin to skin contact with the mother, right? So it is usually indicated for all stable. Okay, the word stable is important. Of course, if the baby is in shock or having distress, you will not do it. So all stable low birth weight babies, it is recommended to do kangaroo mother care, right? And kangaroo mother care will help the baby in breastfeeding also, because baby is in skin to skin contact with the mother inside the clothing of the mother, right? It helps in temperature maintenance of the baby, also prevents hypothermia. So it has a lot of advantages, right? So this kangaroo mother care, coming to a question which has been asked multiple times previously, all of the following are the components of kangaroo mother care except. Yes. So who will tell me the answer? A. Use of radiant warmer. B. Exclusive breastfeeding. C. Skin to skin contact. And D. Early discharge from hospital. So what is the correct answer? So Hassan, MS, Dopamine, High Tracker, Divya, Revati, Neha, Anna, Pradeep, Gajendra, Karishma. Very good. Awesome. So use of radiant warmer is not a component of kangaroo mother care. Exclusive breastfeeding is skin to skin contact, and this kangaroo mother care helps in early discharge of these baby from hospitals. Okay, so these are the components of kangaroo mother care, but use of radiant warmer is not a component of kangaroo mother care, right? So, what are the advantages of kangaroo mother care? Why are we propagating it, right? So, one is, it decreases, it protects the baby against multiple things. So, let us see what all. So, it protects the baby against hypothermia, right? Because baby is kept in skin to skin contact, gets the warmth from mother's body. So, protects the baby against hypothermia. Okay. What else? So, it, helps in exclusive breastfeeding. Exclusive breastfeeding, as baby can, conveniently breastfeed whenever required. So, exclusive breastfeeding rates are higher. It decreases the chances of nosocomial infection, okay, or sepsis. Decreases the chances of nosocomial infection or sepsis, okay. Decreases the risk of neonatal mortality. It has been seen that it decreases the risk of neonatal mortality also, right? And it has been seen that if kangaroo mother care is done, then it shortens the length of hospital stay. So shortens the length or duration of hospital stay. So these are some of the advantages why kangaroo mother care is recommended, right? Okay. So moving on to what are the problems in infant of diabetic mother. So if a mother is diabetic, and especially if the blood sugar control of the mother has been bad in the periconceptional time or in the first trimester, then this baby is going to have certain problems, increased risk of certain problems rather. So what all are they? So baby is going to be large for date. Why large for date? Because excess of insulin is secreted, right? So this insulin acts as a growth factor. So hyperglycemia is there, excess of blood glucose goes to the fetus, fetal pancreas is stimulated, excess of insulin is secreted, and insulin is a growth factor for fetus, remember. So baby is going to be large for date. Now if the baby is going to be large for date, there will be difficult or prolonged labor. Okay, difficult or prolonged labor will be there, right? More chances of birth trauma because you might have to use forceps and all. So more chances of birth trauma will be there, right? And the baby will have, because of the prolonged labor, more chances of perinatal asphyxia. Okay, more chance of perinatal asphyxia, right? Now what all metabolic problems? Very very important, asked n number of times. So very important, in infant of diabetic mother there are chances of hypoglycemia in the baby, not hyper, it is hypoglycemia. So three things are hypo in these babies. So chances of hypoglycemia is there, hypocalcemia and hypomagnesemia. Okay, hypoglycemia, hypocalcemia and hypomagnesemia. And the bilirubin levels can be usually high, so there is hyperbilirubinemia. Okay, hyperbilirubinemia or jaundice. Now hematologic problems, so there are more chances of polycythemia in these babies. Okay, there is more and more extramedullary hematopoiesis, so polycythemia. In the respiratory system, these babies have more risk of RDS or respiratory distress syndrome because they have delayed maturation of surfactant. Okay, so even term babies born to diabetic mothers can have respiratory distress syndrome or hyaline membrane disease due to the delayed maturation of surfactant, right? Now, cardiovascular problems, congenital heart diseases as a group are most common congenital abnormality in infant of diabetic mother. Now, among the congenital heart diseases, if you ask, so most common would be VSD or ventricular septal defect. But the most specific congenital heart disease in infant of diabetic mother is TGA or transposition of great arteries. So most specific would be TGA or transposition of great arteries. And there's also asymmetric septal hypertrophy or HOCM, hypertrophic obstructive cardiomyopathy, which might be more common in these babies, right? Neurological problems, again, the most common would be neural tube defects. But the most specific congenital abnormality in infant of diabetic mother, what is it? Yes, anyone? The most specific congenital abnormality in infant of diabetic mother, very good, Revati. So it is caudal regression, okay, and Niyati also. So sacral agenesis or caudal regression syndrome, that is the most specific, okay. Sacral agenesis, so these have been asked multiple times, sacral agenesis or caudal regression syndrome, okay. Right. Now, among the renal system, there are more chance of congenital abnormalities like, horseshoe kidney, duplication of ureter, congenital hydronephrosis. So, horseshoe kidney, duplication of ureter, hydronephrosis, renal vein thrombosis, and so on. Okay, renal vein thrombosis, right? In the GI system, small left colon syndrome or lazy left colon syndrome. Okay, small increased chances of small or lazy left colon syndrome is there, right? And among the long term problems, these babies can have blindness. Okay, there can be blindness, obesity. When these babies grow up, they can have blindness, obesity, non ketotic hypoglycemia, and diabetes mellitus as well. Okay, diabetes mellitus. You can remember them by the mnemonic BOND. Okay, blindness, obesity, non-ketotic hypoglycemia, and diabetes mellitus. So many problems are possible in infant of diabetic mother, but they are not there in infant of diabetic father, right? So these problems are more if the glucose control is bad in the periconceptional time or in the first trimester. But if there is only gestational diabetes, there is not much risk of these problems, right? Now, moving on, who can answer this question? So, infant of diabetic mother is at risk of development of which of the following? Is it A, hyperglycemia, B, hypoglycemia, C, anemia, and or D, diarrhea? Yes? So, very easy now. So, Amritansh, Rain, Divya, Preeti, Manisha, Vikrant, Dopamine, Ahsan, High Tracker, Ankur. Very good. All of you right. So, it is hypoglycemia and not hyperglycemia, remember. Okay? Now, identify the abnormality in the following X-ray of a newborn with respiratory distress. What is it? Is it tracheoesophageal fistula or congenital diaphragmatic hernia or congenital lobar emphysema or congenital cystic adenomatoid malformation? Yes. So, very good, guys. So, I'm really impressed. Saurabh, Manisha, Pavan, Sandeep, Snesh, Samshad, Sudisha, Isha. Very good. So, it is indeed congenital diaphragmatic hernia. So, what is congenital diaphragmatic hernia? So, it is nothing but a defect of the diaphragm. So, can you appreciate that you cannot see the diaphragmatic border here. So, there is a defect in diaphragm here through which the abdominal contents, that means the bowels, have herniated into the thorax. And you can see the bowel gas shadows. So, these are the bowel gas shadows that you can see in the thorax. And this has led to mediastinal shift. You can see that the cardiac shadow has shifted to the opposite side. So, this is congenital diaphragmatic hernia, which is a diaphragmatic defect through which the abdominal contents can herniate into the thorax, right? And it is often accompanied by varying degrees of intestinal obstruction as well. So, congenital lobar emphysema, the picture is not going to be like this. One of the lobes is going to be hyperinflated, and congenital cystic adenomatoid malformation is a close differential diagnosis to this condition, but there you will see a clear diaphragmatic border. But here you can see that there's a diaphragmatic defect, right? Okay. So moving ahead, and we already mentioned congenital diaphragmatic hernia is a very important contraindication to bag and mask ventilation, right? Now moving on to what are the differences, or from a given case scenario, how can you make out whether it is physiological jaundice of newborn or pathological jaundice? So yes, newborns have a physiological jaundice also, which is absolutely normal phenomenon seen in 60% of term neonates and 80% of preterm neonates, right? So how do you distinguish from a given case scenario whether it is physiological jaundice or pathological jaundice? So, jaundice in babies have a cephalocaudal progression. That means first the face will become yellow. If it is more severe, the chest will be yellow. More severe abdomen, more severe legs will be yellow. And in the most severe form of jaundice, the palms and soles are going to be yellow, right? Now, physiological jaundice is never very severe. So, in physiological jaundice, what happens is palms and soles are never stained yellow. So, palms and soles not stained yellow. Okay. While in pathological jaundice, palms and soles may be yellow. Okay, palms and soles may be yellow. Right? What else? Physiological jaundice is always unconjugated hyperbilirubinemia. Okay, it is always unconjugated hyperbilirubinemia. So, there is no high colored urine. Urine does not stain the diaper, and no pale stools. So, always unconjugated hyperbil, right? So, urine does not stain the diapers. So, no high colored urine. Urine does not stain diapers, right? But in pathological jaundice, it can be either conjugated or unconjugated. So, high colored urine and pale stools may be seen. So, high colored urine and pale stools. So, from a given case scenario, using these points, you can distinguish whether it is physiological jaundice of newborn or pathological jaundice. So, high colored urine and pale stools possible, may be seen, right? What else? So physiological jaundice of newborn, this physiological jaundice usually does not persist beyond 2 weeks in terms and 3 weeks in preterm babies. So does not persist, okay, beyond 2 weeks in terms and 3 weeks in preterms. While pathological can last for a longer time, okay, can last for longer time. And what else? This physiological jaundice never appears. The clinical jaundice and physiological jaundice never appears in the first 24 hours of life. So in first 24 hours of life, if any newborn baby is having jaundice, that is always pathological. Okay. So never appears, very important, never appears in first 24 hours of life. Okay. So these points from a given case scenario will help you pick up whether it is physiological jaundice of newborn or pathological jaundice that requires treatment. So never appears in first 24 hours of life, while pathological jaundice may appear in first 24 hours of life also, right? Okay. So moving ahead, a little bit more about neonatal jaundice. For the treatment of neonatal jaundice, we all know the treatment is phototherapy. So phototherapy, the most important, the wavelength that is used, the most commonly used wavelength for phototherapy or the most effective wavelength for phototherapy is around 450 to 460 nanometers, right? And this is this blue light. You can see this blue light. So if you're getting a picture where a baby, and you can see the eyes of the baby is covered, the genitalia is covered, and the baby is otherwise lying naked under this blue light. So this is phototherapy being given for neonatal jaundice. You can get it as an image-based question also. So sometimes if the most effective wavelength 450 to 460 nanometers is not mentioned, then you can choose any wavelength that includes that range. So any range that includes this. So it can be 425 to 475 nanometers or 430 to 490 nanometers and so on. Right? Now this phototherapy, it acts by various mechanisms. What are they? So the most important mechanism by which phototherapy acts is structural isomerization. So there are multiple mechanisms, but the most important one is structural isomerization. Okay, structural isomerization, where this bilirubin is converted to lumirubin. Bilirubin is converted to a structural isomer, that is lumirubin. Okay, there are other methods also, or other mechanisms also, like photoisomerization and photooxidation, which are less important. Okay, so these are the mechanisms by which phototherapy acts. Moving ahead to our next question. So in a neonate on phototherapy, the bilirubin is converted into, so predominantly it is converted into either A, biliverdin, or B, lumirubin, or C, urobilin, or D, stercobilin. Yes. So I hope all of you are awake. Yes, very good. So Niyati, Medic, Revati, Ranveer, Dopamine, Teja, Mukesh, Amritan, Shankur, Anna, Siva, Satish, Ramesh, very good. So bilirubin is converted into lumirubin, which is a structural isomer of bilirubin, right? Okay. Now, what are the adverse effects of phototherapy? Very important. Previously, the question has come. Bronze baby syndrome is a complication of. So, answer is phototherapy. So, we need to know some important adverse effects of phototherapy. So, they are like bronze baby syndrome. Okay. So, the color of the skin of the baby becomes dark if a baby is on phototherapy. So, that is called bronze baby syndrome. Okay. So, there can be bronze baby syndrome. Then these babies can have watery diarrhea because, the bile isomers or salts that are formed, they irritate the intestinal epithelium. So, watery diarrhea can be there. Because of watery diarrhea and increase in sensible losses, also there can be dehydration. Okay, there can be dehydration. There are chances of hypocalcemia as well. Okay, hypocalcemia can be there. And these babies can have retinal toxicity. So that is why it is recommended to keep the eyes of these babies covered. So retinal toxicity can be there, and there can be gonadal toxicity or mutation. So that is why the baby has to be, diaper has to be there covering the genitalia, because gonadal toxicity or mutations are possible, right? Okay. And there is, of course, there is impaired maternal child bonding also, because breastfeeding and all is going to be difficult. So impaired bonding between the baby and the mother, because baby has to be kept separately from the mother for doing phototherapy. So these are some important adverse effects of phototherapy. So these were some very, very important must know topics from neonatology, right? Moving ahead to some topics from systemic pediatrics, which are important for us. So pediatric cardiology. So we must know the auscultation finding in various congenital heart diseases. So in ventricular septal defect, what do you get on auscultation? So usually what we get is a pansystolic murmur. Okay. So a pansystolic murmur, right? So we have discussed the pathophysiology, why these murmurs are there, all this in detail in our videos, and I'm sure you all know that. So this is the time for just revision. So ventricular septal defect, you get a pansystolic murmur. Atrial septal defect, you usually do not get any murmur. What you get is a change in the second heart sound, and what is that? You get a wide fixed split of the second heart sound. Okay. In addition, in a large atrial septal defect, you can get some flow murmurs as well, right? Patent ductus arteriosus, typically what murmur do you get? Yes, so waiting for your answers now. Patent ductus arteriosus, typically what murmur do you get? Yes, let us see who can answer. Patent ductus arteriosus. Very good. So you get a continuous murmur. Prithvi, Sarthak, Satish, Sneha, Kapil Dev, Akhil Raj. Very good. So continuous machinery murmur. Medic, very good. Right. So you get a continuous machinery like that, a murmur. Okay. So continuous machinery murmur. Okay. In patent ductus arteriosus. Right. Tetralogy of Fallot, what do you get? So tetralogy of Fallot, we get ejection systolic murmur. Ejection systolic murmur in the pulmonary area. And we also get a single second heart sound. Okay. So P2 is soft and inaudible. So only A2 is heard. We get a single second heart sound. Okay, instead of the two components. So these are the important auscultation findings in various important congenital heart diseases that we must be aware of to pick them up from a given case scenario. Okay. Now, some important chest X-ray findings that you get in various congenital heart diseases. So in which heart disease do you get an egg on side appearance? Yes, waiting for your answers. Egg on side appearance you get in which heart disease? Very good, Dr. Rain, Ranveer, Divya, very good. Teja, Dr. Sarika, Sanjay Kumar Patnaik. So you get it in TGA. TGA, that is transposition of great arteries, or it is also called transposition of great vessels. Okay. Very good. Snowman or figure of 8 appearance, where do you get it? Snowman or figure of 8 appearance we get in supracardiac TAPVC. Okay. Supracardiac TAPVC, that is total anomalous pulmonary venous connection, where the pulmonary veins, instead of draining into the left atrium, drain into the right atrium, right? Excuse me. Okay, so supracardiac total anomalous pulmonary venous connection, right? 3 sign and notching of inferior margins of ribs. Where do you get it? So we get it in coarctation of aorta, where there is a narrowing in aorta. Okay, coarctation of aorta, very important. Boot shaped heart is a must, no question. Again, n number of times you've got core and sabot appearance or boot shaped heart. Okay, so core and sabot appearance or boot shaped heart, where do you get it? So very good. I can see Medic, Gridri, okay, med student, Niyati, Ranveer, Rachna, Afreen, very good. So you get it in tetralogy of Fallot. And box-shaped heart, where do you get it? So box-shaped heart or a huge cardiac shadow, we get it in Epstein anomaly, okay? So in Epstein anomaly. Epstein anomaly, we get a box-shaped heart, right? Very good. So moving ahead. So here you have a question, a 6-year-old child presented with hypertension. Okay, 6-year-old child with hypertension. On examination, the lower limb pulsation was feeble. That means there is some narrowing somewhere. You know, in the from arch of aorta to descending aorta, there is some narrowing. So the lower limb pulses are feeble. Upper limb pulses were normal. On chest X-ray, notching of the ribs is noted. What is the probable diagnosis? So can you appreciate this notching of ribs? Right, so this you can see the notching of inferior margin of ribs is there. So inferior margin of ribs are notched like this, right? So notching of inferior margin of ribs is there. So what is the best answer? So is it tetralogy of Fallot or Epstein anomaly or transposition of great arteries or coarctation of aorta? Yes, so what is the answer? So notching of inferior margin of ribs, very good. Aniket, Samar, Rain, Akhil Raj, Hemant, Shifali, Vinay, very good. So it is coarctation of aorta. Okay, so there is a narrowing in aorta, and because of that, the lower limb pulses are feeble. Okay, feeble femorals, feeble lower limb pulses, and you get this notching of inferior margin of ribs due to the formation of collaterals between the anterior and posterior intercostal arteries. Okay, vessels. So what do you see in this X-ray? So this, of course, you know, is the boot-shaped heart. You can appreciate the shape of the heart is just like a boot. So this is tetralogy of Fallot, okay, boot-shaped heart. So these are very, very important image-based questions that you can get, right? So moving ahead, what do you see here? So what do you see? So the cardiac shadow is huge and it is just like a box. So what is it called? So this is a, yes, come on. So this is a very good, Divya Reddy. Okay, so this is a box shaped heart that you get in Epstein anomaly, right? So box shaped heart, okay, in Epstein anomaly. Very good, right? So again, a very important image based question. Okay, and you can get Himalayan P waves in the ECG in Epstein anomaly, right? This is the egg on side appearance. You can see the shape of the cardiac shadow is just like a egg. So egg on side appearance, and that we know we get in, where do you get the egg on side appearance? We already discussed. So very good. Vashishta, Samar, Mukesh, Teja, Renuka, Sarthak, Karishma, Dopamine, Prithvi, right? So we get it in TGA, or transposition of great arteries, right? Moving on to a few questions from hematology. So a child presented with generalized weakness, okay? His hemoglobin level was low and serum iron was low. Which of the following vitamins would help in iron absorption? So we know iron deficiency anemia is a very, very common problem in children, and in fact it is the most common nutritional disorder that is seen, right? So in iron deficiency anemia, we know which of the following vitamins help in iron absorption? Is it vitamin C or B12 or A or E? So very good. Dr. Sonia, Soumya, Salam, Lucky Yadav, Renuka, Prithvi, very good. So it is vitamin C. So vitamin C helps in iron absorption, right? A little bit about sickle cell disease. We know it is because of the point mutation in the 6th codon of the beta globin, where there is replacement of a glutamate with valine. So as a result, there is formation of HBS, sickle cell, right? The sickle hemoglobin. So it is the most common structural hemoglobinopathy, and most common clinical features are acute painful crisis, increased incidence in osteomyelitis due to salmonella. So infection due to salmonella is very common. Osteomyelitis due to salmonella. And if there is heterozygous, so this is an autosomal recessive condition. So if it is heterozygous, it is called sickle cell trait. If it is homozygous, it is sickle cell disease. So heterozygous sickle cell trait is seen to protect against falciparum malaria. And these sickle cells appear like this. So they are sickle-like in shape. You must have seen a sickle, which is a knife-like thing which is used for harvesting the crops and all. So this is a sickle. So this is the sickle cell anemia or sickle cell disease, where there is HBS, okay, which is very sticky and leads to deformation of the RBCs. A little bit about a very important coagulation disorder is hemophilia, from which often you get questions. So the inheritance of hemophilia is, remember, X-linked recessive. So it is of course more commonly seen in males, okay. You might get a history that the maternal uncle, mother's brother also had similar complaints and so on, right? Hallmark of hemophilia is bleeding. So coagulation disorder, you get deep bleeding in the joint. So hemarthrosis is the hallmark, okay. And earliest joint hemorrhage is usually seen in ankle, right? Ankle is the most common, followed by knee, okay. So knee swellings often you get in image based questions and case scenarios, right? Laboratory findings are increased APTT. So APTT is increased, right? Because it is the intrinsic pathway that is mostly affected. So increased APTT. While if you do a prothrombin time, that is normal, the bleeding time is normal, and platelet counts may be normal. But still, the child will have bleeding, especially, if there are contact sports or trauma. So deep bleeding is very common. Okay. The treatment is factor replacement, and long-term complications are like chronic arthropathy, development of inhibitors to factor VIII, and the risk of transfusion transmitted infections, right? Now moving ahead to the next case scenario, what we have here is a 5-year-old boy who presented to OPD with recurrent joint pains and swelling since last 2 years. There is also progressively increasing swelling of the knee joints. You can see the swollen knee joint here, right? Can you appreciate the knee joint appears swollen? And there is a family history of similar illness. Okay, so family history of similar illness is present in the maternal uncle. What is the probable cause? So is it ITP or hemophilia or osteosarcoma or thalassemia? What do you think? So very good. MS, Tanya, Dr. Strange. It's really a strange name. Rachna, Shraddha, Sarat, Ujwala, Pradeep. Okay, Siraj, Gausalya. Very good. So it is indeed hemophilia. Okay, so it is a coagulation disorder that you see here, right? So moving on to the pediatric respiratory system, some important points that we need to remember. So if you are getting an infant or a child with stridor in an otherwise well baby, you will think of a condition like laryngomalacia, okay, where the larynx, the epiglottis is very long and floppy and folds on itself. So these babies usually have stridor beginning around 2 weeks age, which progressively increases like to 6 to 8 weeks or so. And they have stridor which increases on crying but decreases when the child is made in prone position. And usually no treatment is required. It is a self-limiting condition. So it is in fact the most common cause of stridor in infants. Okay, that is laryngomalacia, right? Now, if you are getting stridor in an infant or a child who is having low-grade fever with cough, you think of, croup, okay? Croup, or it is also called acute laryngotracheobronchitis, LTB, laryngotracheobronchitis. It is a viral illness. But if you are getting a sick child with high-grade fever and stridor, okay? Sick child with high-grade fever and stridor, then what do you do? So we think of a disorder that is called acute epiglottitis, okay? So that is a bacterial disorder where the child is quite sick. So, a child with stridor can have so many differentials based on what exactly is the case scenario. So laryngomalacia is otherwise innocuous, okay? And this low-grade fever with cough, then you get suspect a viral illness like croup. And sick child with high-grade fever, you will think of acute epiglottitis, right? So how do you differentiate from a given case scenario whether it is croup or acute epiglottitis? What are the differences? It is very, very important for solving your MCQs, right? So etiology, as we already mentioned, croup is a viral illness, okay? So croup is a viral illness. The common causes usually are para-influenza group of viruses. So para-influenza viruses. Acute epiglottitis, on the other hand, is a bacterial illness. So previously it was believed to be most commonly caused by H. influenzae. But with the H. influenzae vaccination that is now going on as a part of the pentavalent vaccine, now the most common cause is streptococcus, okay? So streptococcus is the most common cause, followed by H. influenzae, which remains common especially in the unimmunized population, okay? Clinical presentation, croup, it will be a low-grade fever with stridor, okay? And it will be like a viral prodrome-like thing, okay? Low-grade fever, stridor, and otherwise, the child will not be very sick. But acute epiglottitis, there's going to be high-grade fever and the baby is going to be like really sick, okay? So high-grade fever in a really sick child, so sick that the child is not able to even swallow his or her own saliva. There's drooling of saliva. So very sick-looking, toxic appearance, you think of acute epiglottitis. Again, of course, with stridor. X-ray picture, croup, what do you get? So in croup, what we get is something known as steeple sign, okay, which is like, the airway is like the steeple of a church, okay. So there is a narrowing of the airway and it is just like the top of a church. And acute epiglottitis, you get a thumb sign because the epiglottitis is swollen. Acute epiglottitis, the epiglottis is swollen, so you get a thumb sign, right? And what about the treatment? So croup is a viral illness, so it is mainly supportive care. Plus you use steroids, okay, steroids. Usually dexamethasone is used, okay, oral steroids or dexamethasone is usually used apart from supportive care and oxygen if required. Well, acute epiglottitis is a bacterial illness, so you need to give IV antibiotics, the third generation cephalosporins, along with, of course, other treatment. So in croup, dexamethasone and nebulized adrenaline is usually used for treatment, okay, based on the severity, right? So now moving to the next question, a child with difficulty in breathing had steeple sign on X-ray. What is the treatment? So what is the diagnosis here? If there is steeple sign on X-ray, what do you think is the diagnosis? Right, so steeple sign on X-ray, what is the diagnosis? Come on. So where the steeple sign on X-ray is there, so you will think of croup or acute laryngotracheobronchitis, okay, right? So it is a viral illness. It is not a bacterial illness. So how will you treat it? With antibiotic and steroid, or with oral steroid only, or antibiotic, cough suppressant and decongestant, or reassure the patient? So this is a tricky one. But yes, many of you are getting it right. Very good. So Lucky Yadav, Satish, MS, Kapil Dev. Very good. Teja, Summer, Invisible, Dr. Invisible. Nice name. Again. So this is a child with croup. Okay. And because croup is a viral illness, there is no role of antibiotics. Okay. Reassuring the patient alone is not going to work. Oral steroid is the best answer here. Right. So this is what is the thumb sign. Can you appreciate this epiglottis is looking like a thumb here. So this is the thumb sign and this is the steeple sign. Okay, you can see the airway is narrowed here just like the steeple of a church. You can see the steeple of the church here, right? So moving ahead, what is the most common cause of inspiratory stridor in an infant? Most common cause of inspiratory stridor in an infant, is it laryngomalacia or is it infection due to parainfluenza virus or epiglottitis or vocal cord paralysis? So this is a fairly simple one. Very good, and all of you are answering it correctly. Rachna, Divya, Siva, Samar, Teja, Vikrant, Sonia, Vinay, Vashishta, Prithvi, Dopamine, Kapil Dev, Sandeep. Very good. So it is laryngomalacia, right? Now, a little bit about IMNCI classification of a child with cough or difficulty in breathing. What is IMNCI? So it is Integrated Management of Neonatal and Childhood Illnesses, right? Okay. So this IMNCI classification classifies these children into three categories based on the severity. So the pink category is the most severe category, which is called severe pneumonia or very severe disease. So if a child is having any general danger sign or stridor in a calm child, then we label it as severe pneumonia or very severe disease. Okay. What are the general danger signs? So if the child is not able to drink, or if an infant is not able to breastfeed, so much distress is there, right? Or if the child vomits out everything multiple times, if there is persistent vomiting, convulsions or seizures are there, okay, or if the child is lethargic or unconscious. So these are general danger signs. So if a child with cough or difficulties in breathing is having any of these general danger signs, you label the child as having severe pneumonia or very severe disease. And what do? You give first dose of antibiotic and refer urgently to the hospital. And this is, written in pink area. So that means this child is in most severe or dangerous situation, right? Demanding urgent treatment. Now, if a child is having either chest indrawing, okay, either chest indrawing or fast breathing, then you label it as pneumonia. Okay, you label it as pneumonia, right? So when do you call it fast breathing? Very important to know. So in a child less than 2 months of age, you call it fast breathing if the respiratory rate is more than 60 per minute. In 2 to 12 months age, you call it fast breathing if the respiratory rate is more than 50 per minute. Okay. And in 1 to 5 year age group, you call it fast breathing if the respiratory rate is more than 40 per minute. So that is very, very important for you to know from a given case scenario whether the child is having fast breathing or not. If there is either fast breathing or chest indrawing, then it is labeled as pneumonia. And if there is pneumonia, how do you treat it? You give oral antibiotics, okay? Give oral amoxicillin for 5 days. If wheezing is there, in addition, you can give bronchodilators, okay? If it is a HIV positive child, then you might need to, refer to hospital. If coughing for more than 2 weeks is there, you work up for tuberculosis, okay? And you have to follow up the child in 2 to 3 days. So this is how you manage pneumonia according to the IMNCI algorithm. If there are no signs of pneumonia, that means if there is no fast breathing, no chest indrawing, no general danger signs, okay? If none of these is there, then you label this child as having cough or cold only. So it is called no pneumonia, cough or cold only, okay? And in that child, you just need to give, soothe the throat and give some home-based care. If wheezing is there, you might use bronchodilators. If coughing more than 2 weeks, again, you advise for workup for tuberculosis and you reassess the child. So that is as per the IMNCA algorithm, and you get multiple times question related to it, right? So moving to a question, a 3-month-old baby, okay, 3-month-old baby presents with fever and respiratory rate of 60 per minute. He is feeding well, has no stridor, no chest indrawing, no convulsions, okay. So no general danger signs are there, right? But this is a 3-month-old child. When do you call it fast breathing in a 3-month-old child? So remember we mentioned it is fast breathing in a 3-month-old child. So less than 2 months, more than 60 per minute is fast breathing. 2 to 12 months, more than 50 per minute is fast breathing. Okay, respiratory rate more than 50 per minute is fast breathing, right? So the respiratory rate in this baby is 60 per minute. So there is fast breathing. So what will you label this child as? So there is fast breathing, but no chest indrawing, no general danger signs. What do you call it? So is it pneumonia or severe pneumonia or very severe pneumonia or no pneumonia? Very good. I'm really happy that you guys are answering it so perfectly. So Shiana, Yashti, Arjun, Reshma, Revati, Alia, Guevara, Teja. Okay, so all of you are right. Sneh, you're not right. It is not severe pneumonia. So this is pneumonia only. Okay, because only fast breathing is there. Okay, and there is no chest indrawing, no general danger signs, nothing else. So it is pneumonia, right? Okay. Moving ahead to the next question, one more to practice on this. So a 2-year-old child presented to a primary health center with complaint of difficulty in breathing. On physical examination, chest indrawing was present with respiratory rate of 34 per minute. What is the best next step of management? Okay. Whether it is severe pneumonia, start IV antibiotic and ensure immediate referral, or moderate pneumonia, admit in the hospital, Or pneumonia, give oral antibiotic and follow up after 2 days at PHC. Or D, no pneumonia, cough and cold only, no need of specific treatment. So what is the answer, guys? So this is again a tricky one. Let's see if you are able to answer it. So again, in these kind of questions, don't get bogged down by long questions. Just try to analyze it, okay? So it is a 2-year-old child with some difficulty in breathing, and there is chest indrawing. So chest indrawing is there. That means it is at least pneumonia, okay? Either fast breathing or chest indrawing, if it is there, it is pneumonia, right? And on top of it, if there is any general danger sign, then you call it very severe pneumonia or very severe disease. Severe pneumonia or very severe disease, right? So chest indrawing is there. Respiratory rate is 30 per minute, 34 per minute. Is it fast breathing? So we said 1 to 5 years of age, it is fast breathing if the respiratory rate is more than 40 per minute. But here it is 34. So it is not fast breathing. But still, chest indrawing is there. So chest indrawing is there means it is pneumonia. So it is pneumonia. So what will you do? You will give oral antibiotics. So let us see who all have been able to answer it. Hemant Raj, very good. Revati, Dr. JP, Tanya, very good. So it is pneumonia. Give oral antibiotic and follow up after 2 days at PHC. Very good. Okay. Right. So I hope you are getting it, how to analyze and how to come to the right answer. Okay. So moving ahead to the next question. A 3-year-old child presented with recurrent episodes of diarrhea and abdominal distension. On examination, he was found to have anemia is there, short stature, failure to thrive. That means not gaining weight adequately. An upper GI endoscopy with duodenal biopsy revealed villus atrophy. What is the probable diagnosis? So is it A, intestinal lymphangiectasia, B, celiac disease, C, cystic fibrosis, or D, inflammatory bowel disease? Yes, very important. So very good. Rachna, Satish, Teja, medical doctor, Ashwin, Vinay, Roshan, Vashishta, Maushmi, Suman, Reshma, Revati, very good. Okay. So one of the names is at least I am trying. Interesting. So the best answer here, of course, is celiac disease, because the child is having recurrent episodes of diarrhea is there, abdominal distension. Celiac disease is often associated with iron deficiency anemia, which is again often refractory to treatment. There is short stature, failure to thrive is there, and villus atrophy is a very important finding that you get on duodenal biopsy in celiac disease. And of course, if you do the antibodies, the anti-TTG IgA is going to be positive in these babies, in these children. Anti-TTG IgA will be positive, and you do a Marsh grading of the duodenal biopsy sample, and villus atrophy is there as a part of the celiac disease. Okay, and what is the treatment of celiac disease? It is gluten-free diet. Lifelong gluten-free diet is the treatment of celiac disease, right? Very important. Moving ahead to another very, very important topic, that is acute diarrhea in children. So how do you assess dehydration in a child with diarrhea? So you have to see whether it is no dehydration, some dehydration, or severe dehydration, because you're going to treat it accordingly. So how do you see? So you look at the sensorium of the child. So if the child is otherwise, alert, okay, alert and active, then it is no dehydration. In some dehydration, the child is going to be restless and irritable, okay. So restless and irritable. Then some dehydration, okay. In severe dehydration, the child is lethargic, totally lethargic and floppy, okay, limp, okay, right. Thirst again is normal, okay. The child is normal, having normal thirst, okay, not excessively thirsty, no dehydration. In some dehydration, the child is thirsty and eager to drink, okay, thirsty and eager to drink. While in severe dehydration, the child is, not able to drink, okay, drinks poorly, not able to drink, okay, not able to drink. Okay, so in some dehydration, the child is excessively thirsty, but in severe dehydration, the child is not able to drink. Now, skin pinch goes back normally. So if you pinch a fold of skin and leave it, it goes back quickly. Goes back quickly in no dehydration. It goes back slowly in some dehydration. Okay, but taking less than 2 seconds. But it goes back very slowly, taking more than 2 seconds in severe dehydration. Okay. Now, mucosa of the child is normal in no dehydration. It is dry in some dehydration and very dry in severe dehydration. Eyes normal and sunken in some dehydration and very sunken in severe dehydration. This is again very, very subjective. Tears are normal in no dehydration while they are absent in some or severe dehydration. Okay. So, the most important points are the first three: sensorium, thirst, and skin pinch. So if any of these signs are there, So if the patient has 2 or more signs including at least one of the first 3 signs, then that is the category of dehydration that the child is having. Okay, so that is how you qualify it. How do you treat dehydration in a child with diarrhea? So if there is no dehydration, would you still give some extra fluids? Yes, we will, to replace the ongoing losses. Okay, so replacement of ongoing losses is done 5 to 10 ml per kg per loose stool. Okay, and it is usually given in the form of WHO ORS, oral rehydration solution, right? In some dehydration, you have to give extra fluid. How much is usually given? So 75 ml per kg over 4 hours. If the child is able to accept orally, you give it like as WHO ORS. If the child is not able to accept orally or is vomiting too much, you might have to give it as IV fluids. Okay. In severe dehydration, you are going to give 100 ml per kg. Okay, 100 ml per kg fluid, and it has to be given IV. So the fluid of choice in severe dehydration is going to be Ringer lactate. Actually, the fluid of choice is Ringer lactate in 5% dextrose, but which is not usually available. So practically IV Ringer lactate is the fluid of choice which is used. But remember, 5% dextrose alone is never used. Okay, so IV Ringer lactate. Fluid therapy in severe dehydration, we said it is total of 100 ml per kg. But you split it into, first 30 ml per kg, next 70 ml per kg. In less than 5 years of age, in less than 1 year of age, you give first 30 ml per kg over 1 hour, next 70 ml per kg over 5 hours. So total fluid over 6 hours. While in more than 1 year of age, you give it slowly. First 30 ml per kg over half an hour, next 70 ml per kg over 2.5 hours, and total over 3 hours. And we give it in the form of IV Ringer lactate, right? So the treatment of acute diarrhea in children, 3 things. One is, prevention or treatment. So prevention or treatment of dehydration by giving WHO ORS. So prevention or treatment of dehydration, okay? And you also give zinc. Oral zinc is given, okay? So zinc in 2 to 6 months of age, the zinc dose is 10 mg per day, okay? While in more than 6 months of age, it is 20 mg per day, okay? Right? And zinc helps in quicker recovery from diarrhea and prevents recurrent episodes. It is to be given for 10 to 14 days and continue normal diet. So in acute diarrhea, you need not, alter the diet of the child. You continue normal diet. So continue normal diet, right? Of course, not giving chips and kurkure, right? What is the composition of WHO ORS? Very, very important. So it is, the sodium of 75. Again, you have glucose of 75, potassium of 20, citrate of 10, chloride of 65. So the osmolarity of WHO ORS, very important, is 245. Often has been asked multiple times. So composition of WHO ORS, very important for you. Okay. Now, a 3-year-old child with diarrhea for 2 days was irritable and extremely thirsty. What is the next step? So irritable and extremely thirsty. Right? So this appears to be what? Some dehydration or severe dehydration. So irritable and extremely thirsty. Let us go back to our table. So irritable and extremely thirsty, let us see. So irritable is here and excessive thirst is also here. So these are features of some dehydration. So in some dehydration, you give ORS as 75 ml per kg over 4 hours. So let us see what is the best answer to this question. So is it IV normal saline, or B IV Ringer lactate, or C oral rehydration solution, or D juice? So Sarath, Sayanthani, very good. Kapil Dev, Ramesh, yes. So it is oral rehydration solution because it is some dehydration, and you will give 75 ml per kg over 4 hours, right? Now moving on to pediatric nephrology, nephritic syndrome. What is nephritic syndrome? So nephritic syndrome is a condition where the child has hematuria, okay? Usually it is in the form of cola colored urine, coke, so blackish, reddish black and so on. So hematuria is there. And what else? So there is usually hypertension, okay, hypertension, oliguria or decreased urine output. So oliguria with decreased urine output, and edema. And edema is because there is proteinuria to varying degrees, but the proteinuria is not as severe as you get in nephrotic syndrome. So it is a nephritic range proteinuria. Okay, it may be associated with renal dysfunction. So it may be associated with deranged urea creatinine or azotemia. Okay, so moving to the next question. What you have here is a 5-year girl child who presented with sore throat 2 weeks ago and is now presenting with cola colored urine. Was also found to have puffiness around the eyes and hypertension. What is the diagnosis? So is it minimal change disease, or B IgA nephropathy, or C. Post-streptococcal glomerulonephritis, or D. Hemolytic uremic syndrome. So very good. Karishma, Sandeep, Pooja Jain, Rachna, Har, Dr. Radical, Rupal, Ashwin. Okay. So it is PSGN, or post-streptococcal glomerulonephritis. Minimal change disease usually presents with nephrotic syndrome, where there is, generalized edema and massive proteinuria. IgA nephropathy, usually the hematuria begins 1 to 2 days of, sore throat. So it will immediately begin. But in PSDN, it will take 1 to 2 weeks to appear. Okay, so it is not IgA nephropathy. Hemolytic uremic syndrome, again, it is a triad of thrombocytopenia, microangiopathic hemolytic anemia, and renal dysfunction. So this is also not the scenario here. So it is post-streptococcal glomerulonephritis. Okay. Generalized edema and massive proteinuria. Generalized edema and massive proteinuria is most commonly seen in A. Nephrotic syndrome, B. Acute post-streptococcal glomerulonephritis, C. Renal tubular acidosis, and D. Nephrolithiasis. So what is the best answer? Yes, waiting for your reply. So very good. It is a pretty simple one. Jeetu, Sanjay, Satish, Ishtiyam, Sandeep, Anikesh. Okay, yes. So it is nephrotic syndrome. Okay. So nephrotic syndrome, you get massive proteinuria. And what is massive proteinuria in children? So it is UP is to UC. That means urine protein by urine creatinine greater than equal to 2. Then it is called massive proteinuria. Okay. Right. So the most common cause of nephrotic syndrome in children, what is it? Most common cause of nephrotic syndrome in children is, remember, minimal change disease, where if you do a light microscopy of the renal biopsy, kidney biopsy, no change is seen. Only on electron microscopy you get flattening of the podocytes. So minimal change disease. Okay. Treatment of nephrotic syndrome, initial episode and the relapse, both of them you treat it with prednisolone. Okay. So for the initial episode, you need to give it for 3 months. But for relapse, you need to give it for around 4 to 5 weeks or so. Okay. Steroid dependent nephrotic syndrome, again, you can treat it either with low dose alternate day steroid for a long time, or you can use steroid sparing agents like levamisole. Okay. Levamisole can be used, or you can use cyclophosphamide or mycophenolate mofetil. Okay. Cyclophosphamide or MMF. So these are the options. While for steroid resistant nephrotic syndrome, SRNS, what do you use? We use calcineurin inhibitors. So the drug of choice are calcineurin inhibitors. What are the examples? Like, cyclosporin and tacrolimus. Okay, cyclosporin or tacrolimus. So these are the drug of choice for steroid resistant nephrotic syndrome. Okay. So moving ahead, renal agenesis in a baby is associated with. So is it associated with single umbilical vein, or B. single umbilical artery, or C. polyhydramnios, or D. maternal anemia? So waiting for your reply. So we know by the time your answers come, in umbilical cord, vein is 1. That means normally there is 1 umbilical vein, single umbilical vein is there, but there are 2 umbilical arteries, right? So renal agenesis is associated with Har Chauhan, very good. So renal agenesis is associated with single umbilical artery. So normally there are 2 umbilical arteries, but if there is single umbilical artery, it is associated with more chances of congenital renal abnormalities, including renal agenesis. Okay. Now, moving to a little bit from pediatric neurology, some important topics. Neural tube defects, very, very important. So neural tube defects are basically some defect in the closure of the neural tube. So the examples of neural tube defects are like, meningocele, meningomyelocele, okay, where, a sac of meninges is there, and inside which, there can be some neural components. Okay. Anencephaly is an example of fatal neural tube defect where, the child does not survive. Even if it will survive, the baby will survive for a few hours only, right? Apart from that, encephalocele can be there, and there are some severe varieties also. Okay. So these are some of the examples of neural tube defects. You can pick them up on an antenatal ultrasound, or you can, do a maternal serum alpha fetoprotein, or, acetylcholinesterase levels to pick them up, right? Neural tube defects have a multifactorial inheritance. Okay, multifactorial inheritance. And to prevent neural tube defects, it is recommended that all, children, all mothers in the childbearing age should be on folic acid. So antenatal folic acid, or rather periconceptional or preconceptional folic acid supplementation is what is recommended. So all the mothers should be given 400 micrograms of folic acid per day. Okay. And before planning the pregnancy, at least 1 month before conception, it should be ideally started. And in high-risk pregnancies, the dose is 4000 microgram per day or 4 milligram per day in mothers who have had previous babies with neural tube defect. Okay. So, which of the following is true regarding the inheritance of neural tube defects? Is it A, X-linked dominant, B, autosomal dominant, C, multifactorial, or D, X-linked recessive? So waiting for your replies. Come on. So which of the following is true regarding the inheritance of neural tube defects? Dr. Rain, Revati, Karishma, Soumya, very good. Sneh Patel, Sarika, Dopamine, Teja, yes. So it is multifactorial inheritance, right? A baby was born with neural tube defects. What should have been done to prevent this condition? So mother could have been given folic acid or iron or thiamine or riboflavin. So what is the best answer to this question? A, folic acid, B, iron, C, thiamine, and or D, riboflavin. So we all know the best answer to this is A, folic acid. Very good. Ankur, Siva, Teja, Ihtisam, Ram, Anand, Siddhant, Sandeep, Vicky. So it is folic acid. And we saw the dosage also, which is also important. Which is the most common seizure found in the age group of less than 2 years? So is it A, febrile seizures, B, tonic-clonic seizure, C, petit-mal seizure, or D, myoclonic seizures? So the most common seizure found in the age group of less than 2 years is, waiting for your replies again. So Friendly Doc, Sneh Patel, Karishma, Kumar, so Anand, Prince, very good. So it is febrile seizure. A little bit about febrile seizure before we move ahead. So febrile seizure is not just fever plus seizure. It is basically significant fever. That means a temperature of greater than equal to 100.4 degrees Fahrenheit, along with seizures without any evidence of CNS infection. Because a fever with seizures can be there in meningitis also. That is not febrile seizure. So fever with seizures without any evidence of CNS infection. Okay. In the typical age group of 6 months to 5 years age. Only then you label it as febrile seizure. And it is the most common cause of seizure in under 5 children. Okay, most common cause of seizure in children less than 5 years of age. And febrile seizures are of two types. So they are basically simple febrile seizures and complex febrile seizures. Okay, so simple febrile seizures are what? Simple febrile seizures are generalized. Okay, while complex febrile seizures are focal. Simple febrile seizures, they last for less than 15 minutes, while complex febrile seizures last for 15 minutes or longer. Okay, 15 minutes or longer. And simple febrile seizures, usually there are single episode in a particular episode of fever. Okay, single episode of seizure in a particular episode of seizure, while complex, there can be frequent or recurrent episodes. Okay, in one particular episode of fever. So you can remember the complex febrile seizure by 3 F's. What are they? Focal, 15 minutes or longer, and frequent or recurrent, right? And febrile seizures, basically no long-term antiepileptics are usually required for simple febrile seizures. Only you treat the fever. You can give oral clobazam for prophylaxis. In complex febrile seizures, sometimes long-term antiepileptics like valproate may be required if they are like really recurrent. Okay. Now, moving ahead to our last topic from pediatric endocrinology for today. So a newborn with ambiguous genitalia, okay, was found to have hyperkalemia. So the baby is having ambiguous genitalia. We are not able to make out whether it is a male baby or a female baby, and was found to have hyperkalemia. That means elevated potassium levels and high 17-hydroxyprogesterone, and DHEA, dehydroepiandrosterone. Which enzyme is deficient? Is it 21A, 21 hydroxylase, B, 17 beta hydroxylase, C, 11 hydroxylase, or D, 17 alpha hydroxylase? So Ravi, Soumya, Ramesh, Medic, Hemant Raj, Vikrant Malviya, Sarath, Har Chauhan, Samshad, Kapil Dev, very nice. So it is a case of the child is having congenital adrenal hyperplasia or CAH. Okay, congenital adrenal hyperplasia or CAH. And CAH, friends, is an autosomal recessive disorder. It is most commonly due to 21 hydroxylase deficiency. And if 21 hydroxylase is deficient, there is going to be hyperkalemia and high 17 hydroxyprogesterone and progesterone and DHEA levels. Let us see why. So this is the adrenal steroid synthesis pathway. Okay, so you can see that the green one, this is the mineralocorticoid pathway. Okay, so this is the mineralocorticoid pathway. This is the glucocorticoid pathway, and this is the sex steroid pathway. Okay, so what will happen if there is 21 hydroxylase deficiency? Just try to understand. So if there is 21 hydroxylase deficiency, can you see this 21 hydroxylase enzyme? So if this 21 hydroxylase enzyme is deficient, what is going to happen? The mineralocorticoid will not get synthesized. So what is the function of mineralocorticoid or aldosterone? To absorb sodium, excrete potassium. But there is no mineralocorticoid synthesized. So potassium is not getting excreted. So there will be hyperkalemia, okay, or elevated potassium levels, right? What else? Now, because this mineralocorticoid and glucocorticoid pathway is not happening properly, all the metabolites excess are getting shunted to the sex steroid pathway, and excess of testosterone is getting synthesized. So that is why you can get ambiguous genitalia in a female baby. Okay, so ambiguous genitalia because of the excess of testosterone, right? So we know why hyperkalemia, why ambiguous genitalia, right? Why ambiguous genitalia is there, we know because of excess of testosterone. Now, what will happen? Because this pathway is not able to progress beyond this part, okay, beyond this part, this pathway is not able to go. So what will happen? Excess of this progesterone is going to accumulate, excess of 17 hydroxyprogesterone will be accumulating, and this DHEA levels will also be elevated because more and more of synthesis is taking place. So coming back to our case scenario, let us see. So there is ambiguous genitalia, there is hyperkalemia. We know why, because mineralocorticoids are not getting synthesized, potassium is not getting excreted. High 17 hydroxyprogesterone and progesterone, we know why, and DHEA levels are high. So this is a case of 21 hydroxylase deficiency, congenital adrenal hyperplasia. The most common cause of congenital adrenal hyperplasia we know is 21 hydroxylase deficiency, right? So this is an autosomal recessive disorder, and the treatment of CAH is by giving steroids. So you have to supplement hydrocortisone and fludrocortisone. So glucocorticoid and mineralocorticoid supplementation can be done. And antenatal diagnosis and treatment of this disorder is possible, right? So friends, these are some very, very important topics from neonatology and systemic pediatrics which you cannot afford to not know, right? So remember, I know all of you have worked really hard and you have, put on your best foot forward, and you have really been very sincere and worked really hard. Now, this is the time to consolidate your preparation. Very few days are remaining. This is the time to believe in yourself. Okay, it is very, very important to have your nerves during the exam, to believe in yourself, to have a positive outlook, and if you've worked really hard, remember, you will always, always be able to, achieve your dreams. Don't underestimate yourself. Don't get bogged down looking at others. Focus on your own self. Stay motivated. Keep your nerves, keep cool, and put in more than your 100%. Just focus, 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 and I'm sure you'll be able to crack it. You have to knock this T off can't, and it will be I can and I will. So all the very best for your exams, okay? And I will be waiting for your messages. I'm sure you'll be able to solve all the questions that come from pediatrics. So all the very best, and God bless you. Thank you so much.